all for being here. I know that there are a lot of external things going on right now that have caused a lot of anxiety, and I appreciate you being here. Hopefully today we'll get some answers. And Chris, I'm going to have you help me get out of this. Because I don't know how to get out of YouTube. We could watch some SNL skits. Maybe that would help later. Oh, good. There. That's who I am. So welcome to our first Eggs in the Economy of 2020. This is a quarterly event where we bring together people that might have different perspectives on hot topic public policy issues that are facing our state. So our goal here today is to hopefully educate you all, provide a lively discussion, answer some questions that you might have around Colorado's state budget and the public option bill. At CSPR, we believe strongly in the need for civility, open dialogue, and conversation that's driven by facts. JJ, come on in, grab a plate. There's lots of seats up here. We also believe sound fiscal and economic research is essential to hold up Colorado's economy, vitality, future, and individual opportunity. We believe it's important for Republicans, Democrats, and all the rest of us to break bread together. So for the legislators and elected officials that are in attendance today, could you please stand? Thank you for being here. Thank you for your service. I'd also like to take a moment to recognize our board of directors, an amazing group, and that I have the honor and privilege of working with on a daily basis. The board really cares about the state and the need to improve our state around public policy issues. So board members, could you please stand as well? It's now my privilege to introduce our Director of Policy and Research, Chris Brown. So Chris joined us several years ago. He leads our research efforts as our economist on staff, and even as a DC transplant, which we're not going to hold against you. He knows more about Colorado policy and the budget than many do at the Capitol. So Chris, I'll turn it over to you.
Yeah, thank you so much. I think it's been a year now since we started the Eggs in the Economy, and it's fantastic to see great attendance and share a lot of our research in this format. I think it's a great opportunity, again, to engage and get a lot of feedback. I guess one thing I just wanted, before I turn it over to our first presenter, I wanted to speak about one of the most recent issue we just released. It's on your table. It's we released a chart called Colorado Prices in the 21st Century. So give a handout, take a look. We're hoping to sort of inspire some questions about how the Colorado economy has changed. As I said, we've done this on a quarterly basis for the last year. Last December, we talked about our annual release called the Colorado Budget Then and Now, which gives a high-level overview of where state budget and spending looks over the last 10 and 20 years. And we joked that despite studying in-depth issues like paid leave, issues like the history of education, finance in Colorado, and a range of other topics, this animation happened to be, I think, the best response we got from an audience. So it was interesting, and it played out showing a change in spending, again, over the last 10, 20 years as it relates to total appropriations by individual budget items. So I'll just play this again now, just so you can see it. It's on our website. If you'd like to go and view it a little more in depth, you can. But again, it sort of emphasizes, as we see the Affordable Care Act in 2011, the expansion of Medicaid here in 2015, a significant shift in overall state spending and appropriations as it relates to appropriations to healthcare policy and financing, education, and brings us to where we are today. Again, I won't go into too much depth there, but that shows a history as it relates to state spending. This chart, what we tried to do is show the history as it relates to prices that we face as a household, as individuals. And really, again, I apologize that the chart up here is probably difficult to see, which is why we wanted to give you a printout, but really hope that this can stoke some conversation and a little bit of understanding as to why when we look at the history of how prices of goods and services have tracked against overall inflation, we've seen some items grow significantly faster than others, putting pressure on sort of every dollar of wages. And ultimately is, I think, when you try to dissect some of these elements at the top related to tuition for public higher ed, housing, medical care, electricity, rent, these are really a lot of the factors that are driving our public policy discussion today. And so I'd encourage you to take a look. If anything jumps out to you as that resonates with you in this chart, I'd be happy to take your questions and comments. We look to maybe do some follow-up work on this in the coming months. So with that, I'd like to turn it over to our first speaker, Lauren Larson. We're very fortunate to have Lauren here today. She's the director of the Office of State Planning and Budget, responsible for developing the governor's annual budget request, forecasting state revenue, conducting research, and evaluating various government programs. Prior to joining the state, I guess she's also a DC, maybe not transplant, but spent some time in DC, managed a $50 billion budget at the White House Office of Management and Budget, where she was chief of the Treasury branch under Presidents Bush and Obama. And as someone who looks forward to your quarterly forecasts and all the information your office puts out that's essential for our work, thank you, and thank you for joining us today. So.
Thank you, Chris.
Oh, yes. Sorry. It won't be as easy, right?
And thank you, CSPR, for the invitation. It's great to speak with you all this morning. If you can tear yourselves away from your phones and watching the markets for a few minutes, we'll talk a little bit about the budget environment. I should say we're currently working on a forecast that'll publish a week from tomorrow. And usually about this time in the quarterly cycle, we're pretty much locked down on what we're forecasting and what we're going to say. We even have most of it drafted, and I can say I'm not in that position today. There's a lot of uncertainty, and I can take some questions at the end, but because I'd love to hear what you're thinking. But my thought at the moment is we need to be thinking about a range of outcomes given the uncertainty, and we'll try and inform the policy discussion around the budget by looking at ranges of possible outcomes. So that's where I am right now, and I'll just get that out right away because I know that's of course in everyone's mind. Circuit breaker just tripped for the S&P. There's a lot going on in the markets this morning. So let's put a pin in that for a minute and talk a little bit about the fiscal 21 budget that the governor submitted to the General Assembly on November 1. The top line highlight is that it's about half of the increase that we had last year. That just, no downturn, nothing bad in the economy. It's just we're up against the Tabor cap and caseload pressures are driving the budget. And so there's half as much room as there was last year. So I told everyone last fall, if you open the budget and say, where's my money? And everyone's flipping through to find who got the money. The answer is nobody did, because we have as much new money, and as everyone in the room knows, you have about you are as rich as you feel by how much new money is coming your way, right? You spend up what's in your base budget, and then you feel rich when there's new money that comes your way. So this is the new money, half as big as last year, and we saw this was coming. I was fortunate to be appointed by Governor Hickenlooper as he was for his last budget, and then I thought I'd be out of a job in 5 months, but luckily Governor Polis kept me. And during the transition period, I'd work during the day in Denver and then drive up to Boulder at night, and we would wrestle with this problem that was coming and what should we do, knowing that there'd be a tighter budget environment under a Polis administration. And so part of that led to changing the way we develop the budget. And so before I introduce that, let me just show of hands, who here's had to cut their business or company's budget by 2%? Yeah, almost everyone. Who here has had to cut their company's budget by 5%? Who here has had to cut a budget by more than 5%? Henry's raising his hand. Henry's opening. So, I just asked that same question to the Grand Junction Area Chamber of Commerce, and even it was just 100% hands in the room, and everything was even tighter there. So this isn't a unique exercise. So what we asked the departments to do was to submit a budget request to find 5% savings in their budgets and to cap any increase that they wanted at 2%. And this was sort of a shock for the departments. They weren't used to having to find savings when they were outside of a crisis environment, but it was a great exercise to get a new cabinet familiar with their budgets and understanding, where the fat was, where they had a little room, where they didn't have room, and we ended up sort of changing the way we developed the budget in the state of Colorado. This was, it wasn't just done by the 18 budget directors in the departments. This was change management. It involved hundreds of people across the departments. It involved engaging operational leaders. There was a huge education effort. So we were really proud when the results yielded over $200 million in savings for the budget, of which 73 were precious dollars in the general fund. So these are savings in the base, in our base $30 billion budget, can now be leveraged to fund other priorities. So why, even though we weren't, you'll remember, we weren't forecasting a downturn at the time when we were looking at this, we just saw a tighter environment, a tighter budget environment. Now we're up against the Tabor cap, so the growth in the general fund is limited to population and inflation growth, and we have quite a caseload cost building, and so it's just what's available for new spending is squeezing. There's some other dynamics. Since this is a sophisticated audience, I'll try and give you some flavor. Some other things that can happen in the budget that have nothing to do with changes in the economy. In fact, this is a chart to show how the general fund budget can get squeezed through some extra things that have nothing to do with what's going on with general fund revenue. So the first column is just showing the base budget. You've got cash fund revenue in the bottom, you've got general fund revenue in the dark green, and then you have the Tabor rebates up the top. Well, if your cash fund revenue were to grow, if things were growing great and your cash fund revenue collections were to come in 500 million higher, that's a big number for cash fund revenue fluctuation, not impossible. Maybe about half that might be more normal for fluctuation. But anyway, you can see how that drives up the bottom blue, which then, since we're up against the Tabor cap, it squeezes the general fund revenue available for spending, the dark green, and it increases the Tabor rebates. So you've got more revenue in the door, things are going well, but you've just lost 500 million in your budget. Contrary, since you're above the Tabor cap, if there's a drop in cash fund revenue, which generally you might think loss of revenue, bad times, but in this bizarre case, you end up with more money in the budget, and but not dollar for dollar, because the first drop would eliminate the Tabor rebates that are above the cap. So you've eliminated the light green, the pale green, and then what's remaining would create more room in the budget. So it's a little tricky right now. We're working on the forecast and we're trying to think what's happening in the general fund revenues, but what's also happening in the cash fund revenues, and sometimes they can have counter and opposing effects. There's also more sensitivity. It's a lot of the conversation when we put out the forecast is around the size of that green line, how much the Tabor surplus is, what does OSPB, my office, say versus what does Ledge Council say, the legislators, forecasters, and there's a lot of debate around that. But it makes you think that right now we're like 300, 400 million over the cap, depending who you're, whose forecast you're looking at. But, or sorry, right now, I should say in December. I don't quite know where we are right now. But if the budget's more sensitive than that 300 or 400 million would guess, because we have the first Tabor rebate mechanism goes to the senior homestead property tax credit. So this is an important tax credit. It's going to seniors and disabled veterans. And in years when you're below the Tabor cap, it's just a general fund expense that comes right out of the general fund. When you're above the Tabor cap, it's about 160 million a year. That 160, the first 160 of dollars above the Tabor cap, that gets deemed to the tax credit. So you can fall, right now we're, I think, 270 over the cap. So there's not a lot of room there between 270 and 160. So the forecast could fall by just a little over 100 million, which is nothing, it's budget dust. And all of a sudden you'd be looking at having to rebalance your budget and cut some spending. So we're in a much more, because of this senior homestead interaction and its interaction with the surplus, with what's coming out of the surplus versus what's in the base of general fund, we're much more sensitive, our budget is much more sensitive to changes than it would otherwise be. So those are two more nuanced points that I save for audiences that enjoy numbers and thinking about the dynamics of spreadsheets. So I was delighted to share that with this audience here. Let's see, so given this tighter environment, given where we are in the economic cycle, and again, I've got a pin in what's going on right now because I'm not, I'll come speak to the Joint Budget Committee about that in a week from tomorrow. But just where we are in the economic cycle, longest expansion period in history, we think it's really, really important to save for a rainy day. Are we in a rainy day? I don't know, but I do know Colorado has fallen quite below the national average for our reserves and our preparedness. This is a Moody's analysis about the savings available to get the y-axis there are how many years you could withstand a shock, and you can see Colorado isn't even at a year. So I think this is an important case for urgency on putting aside some money for savings as well as spending. You'll see this is now co-branded with the Treasury, and the Treasurer and I have been out talking about this quite a bit, the importance here. We've formed a CFO council in the government, something I've talked to some of you in the room about, how a corporate CFO function would have budget, it would have Treasury, and it would have accounting. Well, we're 3 separate offices in the state of Colorado, one and the treasurers, separately elected. So we've started meeting regularly every quarter as a team, the controller, the treasurer, and I, to think about our state fisc as a whole and through the lens of more of a corporate CFO. Some other data that might surprise you. Right now, our general fund savings are a little over 900 million. The last 2 recessions, not just the Great Recession, but the last 2 recessions show more than 3 billion in revenue decline. And look how many years it hit. And I've talked to folks who, there's folks in the room here who had to suffer through this pain. The first year, you can squeak by. The second year, there's some accounting adjustments, still, deferred expenses. You have some tricks up your sleeve, but by the 3rd year, things are just so painful. But this is the pattern. This is the pattern of a recession. These numbers aren't adjusted for inflation. So actually the revenue hit was quite a bit more in the 2001 recession than even the Great Recession to the general fund hit. So for this reason, we also think it's important to, one more piece of data to show you. Another thing we're looking at here, and Pew is doing an analysis with the Harvard Kennedy School for us on, figuring out what should our right level of reserves be. We know it's much higher than what we have. We're in the red quadrant here, which means we have high volatility and low reserves. And you can look at some of the other states we're in company with, they're in the red. So what we're proposing, in addition to increasing the general fund reserve, the governor's, and now the treasurer supporting this, to put some guardrails around our reserves and to model best practices in other states that are doing this, to put some deposit and withdrawal rules around our reserves. So you have, for example, Arizona, Michigan, and Indiana. They're basing their reserve levels on personal income growth. So this would be sort of an automatic trigger. If you hit a recession and then you're climbing back up, there's something in law that requires automatic saving without there having to be a separate law passed. One-time windfalls directing into the reserves, like Massachusetts, all their capital gains revenue and one-time legal settlements more than 10 million automatically shoot right into your reserves. Texas, all severance tax revenue, which, obviously like Colorado, they have a pretty volatile income in Texas connected to oil and gas activity. So they have 75% of all severance tax revenue above a benchmark rate directing into a fund. So there's, right now I'm delighted to say the Joint Budget Committee has sent to drafting both the increase in the general fund reserve that we requested and to start thinking to put into statute what some of these guardrails would look like. So we're working on that now with the Joint Budget Committee. And so that's all I have prepared. I'm sure you all have some questions, and I'd love to engage in a dialogue. And I'd love to toss out the first question, which, what do folks think about deciding a budget in the context of such uncertainty, and what should be some of the principles you would advise me for thinking about as we're preparing for this budget season, for this budget setting ahead in the next few weeks.
And just turning.
Good morning. Josh Shea from the Colorado Hospital Association. I don't know how to advise you on the next few weeks. Rest up now, I guess. But I do have a question for you as you are going into that process. There's been quite a bit of new spending over the last couple of years. Knowing that we've kind of got this cliff coming with our budget cycle this year and the potential, what's happening with the markets as we speak, for the R word, how are we kind of as a state grappling with our spending choices this year?
Thanks for that question, Josh. Which the we there involves the Joint Budget Committee and the legislature. I think there's much awareness, and we've been, I've been talking with the JVC since last summer about this changing budget environment. They've been messaging it, I've been messaging it. So I think raising awareness is one way of managing it. I think we need to be very, very cautious about passing legislation that builds out your spending right now. I'm really a true believer in looking at your base spending and I worked for the Bush administration for 8 years, and we kept running this. Mitch Daniels brought in this exercise, this plus minus exercise, but it really worked. And I kept thinking every year departments would run out of ideas for saving and building efficiencies, but like a business, they didn't. When they were asked for it, they had the time to work it and find responsible savings proposals, they were able to find things. So wrong page here. The Obama administration continued that budget development process because it was successful. It's not a partisan thing. It's good business.
A quick follow-up to that.
Yeah.
And I'm curious, in your discussion of the rainy day funds, my understanding is that there is an existing statute for what goes in reserve. Or above that, do you have a sense of what the dollar amount is that would be needed to maybe move Colorado closer to a national average, or what that dollar amount annually is that the administration is looking for?
Yeah, Chris, so The full package of reserves the governor proposed totaled 118 million. But for this general fund piece to move us to the national average, we proposed 31 million November 1st to get from 7.25% to 7.5%. But like a month after we published, the data change and the national reserve went up to 7.6%, and that's another 12.5 million. So it's not. But this chart that you're probably referring to, this involves more than just straight general fund reserve, and it's it's a more detailed Moody's analysis on our preparedness. So I don't know that moving to the 7.5% or 7.6% this year would automatically take us to the middle. It would move us up. But the thing that's happening, I serve on the executive committee for the State Budget Officers Association, and all our states are building reserves right now. I mean, we are building more slowly than a lot of other states, which is why we've fallen. It's not that we haven't been saving and putting money away, it's that we're not doing it at the pace of other states.
I have a question, and it's a political question, and I'm looking for a mathematical answer. Are people paying too much in taxes, or is government spending too much? Mathematically.
Mathematically. Yeah, I think you can look at both ends of the equation. I think right now one of the governor's big goals is looking at tax reform and eliminating some special interest breaks that with a goal to try and reduce rates for everyone. There's definitely a political lens there, but I think you can, a budget at its basic, it's inputs and outputs, and you don't want to ignore either side of the equation.
Thank you so much. Last question. We'll take one more and then we'll move on to our panel.
Speaking of tax reform, being put forth the possibility of changing the taxing system to a progressive type system. What was to be, if that were to pass, what do you all foresee the impact on Colorado?
And you're speaking of I ask your name, please?
Instead of the flat tax.
Yeah, I know, but your name, please?
My name is Bill.
Bill, pleasure. So, Bill, I think that you're talking about the ballot initiative for progressive tax.
If that were to pass.
Yeah, we haven't done the modeling on that yet. That will be something this summer. But that's not what the governor is proposing. It's separate from what the governor is working on, which is a revenue neutral tax reform package. So I'm so delighted. Thank you again for the invitation. I'm a huge admirer of the work. If you guys haven't been on the website, you should check out the new podcast, which I think is a great medium, and I really enjoyed listening to it. So thanks. I hope you'll have me back, and thanks for your efforts to inject data and good analysis into policy debate.
Thank you.
Thank you.
We'll leave more time for questions for the next time as well. Once they get going, they're a lively crew. Okay, well, let me jump into our next topic. Hopefully. And okay, so I'd like to, jump into our next topic and move to our panel discussion, which I'm very eager and interested in hearing this discussion. We've put the discussion and research around Colorado's debates around the public option really at the forefront of our research for the last several months, and we've released 2 papers now on the topic in September of last year and then just in the last month. And it's really in the context of what does the future of healthcare and healthcare policy look like here in Colorado? Currently, the state has, by many rankings, one of the relatively higher ranked healthcare systems overall of any state in the country. Going back to the chart that, again, is on your table when we spoke about, if we isolate the costs related to medical care, they've far outpaced inflation and overall wages, and I think is really what has brought us to the discussion we're having today as it relates to a path forward and what is the best solution to trying to address the issues related to affordability and costs within healthcare that we all face. So there will be more discussion undoubtedly related to what the public option is, and now I understand it's referred to as the Colorado Option Plan. This debate really started, for those of you maybe not as familiar with the issue, this debate really started as of last year. House Bill 19 passed, requiring the Division of Insurance and the state's Department of Healthcare Policy and Financing to propose a recommendation, make a recommendation on what a public option plan would look like. And they were charged with lowering premiums and some other ways of improving the system related to increasing competition, creating a public-private partnership. And I'll let the panel speak to a lot of the specifics on and dig into this. But ultimately, what we've seen out of the Colorado Option Plan, as discussed in the recommendations, would be to create a insurance plan required to be sold by carriers, currently recommended to be sold within the individual market. What that plan would compensate or pay hospitals would be set through a formula established by the state and in statute and advised by a panel of an advisory board that would be created, and it would require hospitals to accept this particular insurance. So where the public option debate has really been trained, and a lot of the research and a lot of the work that has come out from the state in promoting their recommendation has really been trained and focused at the difference between these two lines. So this information comes directly from the state's hospital cost shift analysis released in January of this year, and that's the difference between total payments and total costs, or referred to as margin. So there's an interesting dynamic that just exists fundamentally within healthcare here in Colorado and across the country, frankly, within the healthcare market, and that is that ultimately the margins from commercial insurance, that's employer-sponsored individual insurance, is significantly higher and actually is compensates for the net losses in public coverage. So that's Medicare and Medicaid. And the markets have seen very significant, very consequential disruptions post the Affordable Care Act, post the expansion of Medicaid in 2015. And as the state's uninsured rate has dropped to a historical low around 6.5%, overall losses related to charity care have come down at the same time that we've seen the net losses related to public payers, as we've seen enrollment in Medicaid and Medicare increase. And so the question that's driving a lot of this debate is the increase in margin related to commercial insurance and the net margin as it relates to what public coverage pays. So ultimately, I think what we're trying to understand and drive at is how do we substantially reform what we are paying in health coverage. Now, and the question ultimately is what is driving premium? So as we look at costs on a per adjusted discharge basis, this is a measure that allows us, the state uses to, and many other analysts use to sort of measure on a per unit basis, you could say, a per unit of care basis at hospitals. Costs related to care have gone up by over 5 times as much as the increase in margin. So when you think about what's driving premiums that insurers pay, the underlying costs that are incurred by providers, by hospitals in particular, is contributing over nearly 5.5 times more to the premiums that we're paying. So, ultimately, I think in all of our research, we've acknowledged and talked to the issue related to costs, but the question is, ultimately, given some of the policy framework and policy mechanisms included in the public option and Colorado Option Plan, what are the potential unintended consequences of some of that policy design, as you reduce payments and you don't necessarily fundamentally change the underlying cost of delivering that care. And so we released a study in September that was prior to even any introduction of initial recommendations. So this was based upon broad scenarios we created that do not reflect what is in the current proposal. However, they did articulate that fundamental trade-off we think that providers, hospitals will face as it relates to reducing payments and not, again, changing the underlying cost of delivering that care. As will they make decisions related to how to cut in ways that might impact quality or access, or will those costs be further shifted to the remaining commercial market? We also just released, and I think there's copies of this on your table as well, some questions that we posed after the state's recommendations that we think are still very relevant to understand the potential impacts of this debate on all stakeholders, again, not just isolating some of the premium reductions to the individuals enrolled in the option. Again, so I'd like to turn it to, I apologize for rushing, but we have, I think you want to hear from our panel far more than you want to hear from me. But I'd like to turn it over to Joey Bunch, but I'd like to really acknowledge and thank Representative Roberts for being here today. Given the research we've done, given the work we've put out to really be here to engage in the discussion and share his thoughts as the sponsor of the card option plan. Again, I think it's just an incredible opportunity and really the essence of what we're trying to accomplish with this type of discussion. So I really appreciate, again, the opportunity here and you joining us. So Joey Bunch is the Senior Correspondent Deputy Managing Editor of Colorado Politics. He has a 32-year career, which includes 16 in Colorado. He was part of the Denver Post team that won the Pulitzer Prize in 2013 and a 2-time finalist. And I'm sure you might hear more about his illustrious career from him directly. And so I'll turn it over to Joey. And thank you very much.
Thanks, everybody. You guys have heard me speak before, but I like to talk about myself. And I look at this panel today, and I don't know why in the hell you guys have got me talking, because these guys are way smarter than me. I look at the resume of a couple of these guys, and then Dylan Roberts. I know Dylan, and I got to say, the guy is so much smarter than me. I wouldn't be surprised if the bastard could read my mind. I just let you guys off the hook, by the way, because all anybody's going to remember is I called Representative Roberts a bastard. So I want to invite you guys up. My only expertise here is that I've lived healthcare the last year, because another thing anybody that knows me knows about is I died last year. I shouldn't be here. I went into the hospital with pneumonia, and then I flatlined. I had a heart attack. I was dead for 15 minutes and 40 seconds, and they had to do CPR, and it all came down to the defibrillator. And, that was it. If they didn't get a heartbeat then, that was going to be it for me. So I know the value of healthcare. My whole life depends on it. But on the other side of it, I've spent a year because I'm cheap as hell, and I think about every penny that gets spent. And I've realized that healthcare is a well-oiled machine. It's a twin engine. And one of the engines is healing bodies, and the other is draining bank accounts. That I go to doctors all day long. I'm in there 15, 20 minutes, and then I'm right back out the door. They take my blood pressure, tell me I'm doing great, and they charge my insurance $500. And then the other part of it is I maxed out my out-of-pocket early last year, so there's not an oscopy that I haven't had in the last year. I have done a deal to the insurance company, and that's the system that we have in this country. So guys, let's get up here and talk about this. Maybe you guys can figure it out. Guys, let's start out by just going down the road. Tell us a little bit about yourself and what got you into healthcare and where you think we're headed.
Yeah, thank you all for having me today. Is this on? Okay. Thanks for having me today. I'm Dylan Roberts. I'm the state representative for House District 26, which is all of Eagle County and Rapp County in the mountains. I grew up in Steamboat, and I live in Avon, Colorado now. When I'm not a legislator, when we're in session here, I'm a deputy district attorney for Eagle County. The reason why I've been involved in healthcare, and this is my third legislative session, I've done several bills in healthcare, is because of my constituents. You hear about the great work that the Colorado healthcare industry is doing, and I agree. We have a great quality of healthcare in Colorado, but it's too expensive for too many of my constituents. I hear about the cost of healthcare more than any other issue combined when I'm knocking on doors and having town hall meetings. And we have a lot of people in Eagle County and in Brown County, because those are two of the counties where there's no competition on the individual market, and insurance premiums keep going up and up and up. Some of the most expensive premiums, not only in the state, but in the country. Too many people I hear from are simply not buying insurance and risking it year to year because it's too expensive. And I don't think that's a system we should have in Colorado. We should have people have access to healthcare when they have health emergencies like Joey did. And so that's where I come at this from. But I also, try to live up to my reputation of being smart and want to do it in a careful and responsible way as well. And I think that's what we have with the Colorado option.
Bill Lindsay, is that too loud? Sorry. In the insurance and employee benefit field for over 40 some odd years. For a long time as a broker consultant here in the Rocky Mountain area. In addition to that, I've headed 4 commissions in the state of Colorado for various aspects of healthcare and healthcare costs. So I spent a lot of time studying this very complex issue. And all I would say at this point, introductory comments, is that the economics behind healthcare, especially economics around hospitals, and I've also chaired 2 hospital finance committees for over a period of over 12 years, is very complicated. And so we must be aware of unintended consequences and the implication of policy decisions as they affect healthcare delivery, and the cost.
Good morning, thanks for having me. I'm Rick Rush. I am a independent health actuary. Some people are impressed by actuaries, others not so much. I got into healthcare and health insurance through my actuarial studies. I thought of the things that actuaries can get involved in: pensions, investments, life insurance. Healthcare and health insurance have the most meaning to me because it's what people live every day, and hopefully would have a possibility to have an impact on people's lives. About half my career I have spent in traditional actuarial roles, working as chief actuary for different HMOs and insurance companies. I've run 3 different HMOs. And the other half of my career has been on the employee benefits consulting side, similar to Bill, working with large national and international employers, primarily in their self-funded programs. I had the opportunity to team up with Chris and write one of the papers, co-author one of the papers that Chris talked about with regards to the final report from the state on the state option, and we'll talk about here in the panel some of the consequences, real or unintended consequences that might come from Representative Bill.
Well, Rick, let me ask you the first question, and maybe you guys can join in. Why is it so damn expensive? All of us get sticker shock when we go to the emergency room, when you get a bill to the doctor. Why?
Mainly actuaries. First off, we'll talk more about, understand that there's various insurance programs, various insurance markets. This bill, this discussion addresses the fully insured market. So I'm going to talk primarily about the division of insurance and some of the things that, whether as employers or as individuals, we buy in the fully insured marketplace. First off, let me mention that of the continuum of healthcare costs, healthcare programs, the only piece that's regulated right now in setting prices is the insurance premium. The Commissioner of Insurance, and I happen to think, having worked with various states, that in Colorado we have a very strong insurance commissioner, a very good insurance department. And my actuarial filings, what the insurance companies want to charge, get scrutinized very heavily and are subject to approval by the insurance commissioner. Under the Affordable Care Act, the portion of the premium that can be kept for administration and profit is limited. And the Affordable Care Act is right now 20% of the premium for individual and small employer insurance. So knowing that the insurance company can tack on 15, 20% on top of the cost of care, the driver is the cost of care. And so by various medical economies, various rating regions within the state, we look at what the historical costs have been, what the modifications are as we project into the future. And on top of those projected insurance, on top of those projected medical costs, there's an administrative and profit load. But it's really driven by the underlying cost of care. It's driven by the unit cost, and Chris talked a little bit about that as far as what the unit cost is going up at, as well as the utilization trends, how much more healthcare are we consuming.
Are we being gouged by the hospitals?
It's a free market, and so I would say that I'd start by saying that there are strong negotiations between insurance companies and hospitals on the cost the hospitals pass on to the insurance companies, which are passed on to the consumers. The Affordable Care Act gave us an opportunity with less uncompensated care through Medicaid expansion and other programs for hospitals to improve their bottom line by having less uncompensated care. I think it's the role of the insurance companies as intermediaries for the employed individuals to strike the best deal.
What do you think of that, Bill?
I think that one of the challenges is the Affordable Care Act provided an incentive for hospitals to create accountable care organizations, ACOs. And that was originally driven by the idea of focusing on cost and quality. But what's happened here in Colorado is we have created some gigantic health systems, many of whom, by the way, aren't even hospitals, but they're holding companies that control various hospitals. That gave them quasi-monopoly power in geographic areas. And because there was no regulatory environment to oversee these, they were able to
It was.
Can you hear me okay without the mic? Yeah. Okay. So these health systems have engaged in predatory policies that limit the ability to negotiate, limit the ability of insurance to a company to negotiate or a self-insured employer to negotiate. And because many of these hospital systems are tax exempt, not for profit, don't ever use that word, tax exempt. When their revenues rise, there's no incentive. They don't have shareholders. They don't provide dividends. So that those dollars go into expansion. They go into buying doctors' practices. So right now, about 60% of all physicians in Colorado are employees, no longer independent doctors, as many of us remember. You also have a situation where the hospitals have expanded. I don't need to tell anybody about that phenomenon. You've driven by all the hospital expansion and expanded in areas where arguably additional beds weren't necessary. The hospitals in that same community were only at 50 or 60% occupancy, but yet there's a new hospital being built across the street. If there was no incentive for that not to occur, and then that gets passed on in terms of prices. And so and that's not to blame just the hospitals. We also have a problem with the pharmaceutical industry, but it's a broad issue. And you notice I haven't talked about physicians in this, and that's the reason for that is that by and large, the physicians' incomes have been suppressed because there are more requirements on what physicians have to do in their offices and electronic medical records and other kinds of things. So there's more pressure on a physician to be able to survive these days. And because physicians heretofore haven't been organized as the hospitals have, they haven't been able to use monopolistic pricing strategies to be able to raise their prices. So we have what is a technical term, it's a mess. And it needs to be addressed. The real question is whether or not the public option is the right alternative, in all due respect to the representative, or are there other things that we ought to be thinking about?
Well, sometimes I think politics and governing is kind of like being a clown that twists balloons. You squeeze it in one place and it pokes out in another. And listening to you guys, I'm not sure my life was worth $500,000. I don't know. But now Representative Roberts, you got a foot in all of these circles. What have you learned in the last year about this problem?
Yeah, so, to your point, I think the Colorado option, I'll just say, is not a bill that is intended to fix all of the problems that we have. The Colorado option, I think it's been completely blown out of proportion, to be honest, in Colorado. The TV ads you see on your nightly news and everything thinks we're revolutionizing the way we do healthcare in Colorado. That is not the case. It is just for those who decide to purchase the Colorado option would any reimbursement setting take place or any changes in insurance plans. And that's because that's the problem that we hear about the most is the people cannot buy individual market insurance because it's too expensive. We understand most people like their employer-based insurance, and we're not doing anything to touch that with this bill. We understand that there are other problems that need to be fixed as far as hospitals, insurance companies, pharmaceuticals, and we're doing that in other bills, or it's not being touched by this bill. So my goal in this, and I've been working on this for 3 years now, when I first got to the legislature, trying to figure out how to increase competition in the counties that I represent and many other counties is led us to this point. But yeah, I'm learning that, there are some pretty big cost drivers in healthcare that lead to the insurance premiums rising. I think they just got spelled out, but hospital costs, pharmaceutical costs, and lack of competition allow prices to continue to rise.
Well, and maybe this is why I'm up here, is because this has become such a political issue. Is this the wrong arena to be trying to fix this in the political arena?
I'm not sure. That's a good question. I think if we're able to fix itself, it probably would have already fixed itself. Because healthcare is so vital to all of our lives. The security of health insurance and knowing that you have access to care when you have a health emergency or just to keep your family healthy is an everyday concern for every American. So if this were a problem that was easily fixed, I think it would have already fixed itself.
So what happens next?
So we just introduced this bill on Thursday. So with all due respect to all of the research that's on your table and everything, that's based off of, frankly, not what is in the bill. What was put forward in November was at the result of a bipartisan bill that we passed last year. I had a co-prime Republican sponsor that got that through the House with me, and we got Republican votes all the way through to direct the state to come up with a proposal for a new state option to increase competition and lower costs. That proposal was put forward in November. We worked from the proposal, but the bill we put forward is significantly different than the proposal, and I would encourage you all to read it if you haven't already. But we feel that we've struck the right balance and significantly pared back a lot of the mandates that were in that proposal. We've crafted a formula that I think works for Colorado hospitals. The data shows that the average Colorado hospital will cover all of their costs, including their coverage of uninsured individuals, at 143% of Medicare. The base rate in this proposal is 155%, and our small, independent, rural, critical access hospitals get a reimbursement rate significantly higher than that. There's actually some hospitals that are going to come out better under this proposal than they currently do on the individual market. And again, that's just reimbursement for those who purchase the Colorado option, which is, at most is going to be 5 to 10% of the state. So we're not revolutionizing or asking hospitals to completely change the way that they do business. But where we go from here is that bill was introduced last week. It'll be in its first committee hearing soon, and it'll start moving its way through the legislative process. I'll also say that bill is a starting point. I've been working closely with a lot of stakeholders who are in this room and other stakeholders that their concerns are reflected in the bill we introduced, and we're willing to make changes as we go on too. So we'll go through the sausage making process of legislation.
Well, I learned that the first lesson of politics is math. You got to count the votes, and Democrats have the votes, so they can do pretty much what they want to. And I asked a question at the press conference last week, and I think in that moment I could read everybody's mind because they were thinking, what an asshole. Because I asked this question, I said, is compromise a sign of weakness? Because Democrats don't have to compromise. Yet at the same time, the hospital and healthcare lobby is as polished and as skilled a lobby as there is at the Capitol. So I predict that we're about to have a big fight on our hands, and we don't know exactly how these debates, but if you love politics, buy your popcorn and get a seat on the front row, because this is going to be fascinating. Bill, what do you think is going to happen next?
Well, first of all, I've got to say that I respect the representative so much for taking this tough issue on. This is a really tough issue, and the slings and arrows that he's had to survive despite those deserve to be applauded, and I really do appreciate it. I have two fundamental issues, however, with the bill. The first is the concept of the state of Colorado interfering in a contract between two willing participants, an insurance company and a hospital, and setting the prices, I think is a bad public policy step. Because if the state of Colorado can do that for hospital prices, they can do it for gasoline, they can do it for rent, you just name it, right? And I think that is an overreach that I think has serious policy implications. The second concern is, I know the insurance commissioner, and through this process, because I've talked to him about it, has wanted to demonstrate that he was being even-handed, that he and the group creating the bill were not just going after hospitals. So they decided they'd go after insurance companies as well, requiring two key parts of insurance change. One would be lowering the medical loss ratio, the amount that, as Rick mentioned, that the insurance companies are allowed to keep for administration and so on in the individual and small group market. That's a political play, not a reality play, because when you talk to insurance companies about the challenge that they have in not only billing premiums, but attempting to collect premiums in the individual and small group market, the account receivable component of their financials in those two markets is significant. And so to push that medical loss ratio down to make it look like it's the large group market doesn't take into account the operational realities of what it takes to run an insurance company. And those two markets, the individual and the small group market, are the most volatile. We can talk about that if you care to, that we've had in this state for the last 30 years.
But Bill, who stands up for the little guy? I once described going to the hospital like going to the grocery store, and they put anything they want in my basket. Then they charge me whatever they want when I get at the register. And they said, "Oh, you're in King Soopers, and this came from Safeway. We're going to have to charge you double." Who stands up for me?
Well,
if not Dylan Roberts.
Yeah, I think that's a valid point. I think in the insurance markets we're talking about, the individual and the small group market, the insurance commissioner plays a major role. And you can talk to Rick about his experience working with insurance companies. That rate filing process that they go through is not insignificant, and is not just a simple, pass it across the threshold and we're going to approve it. But I think the other point I was going to make about the bill is it also requires insurance companies to go into markets they're not now in. So we have at least two competing insurers. The problem with that is insurance companies aren't in certain markets for a reason. They're in business to make money, and if there was the main reason why they're not in many of those counties is because there aren't a lot of people in those counties that would buy the product. So you have an unaffordable circumstance that could occur there. And again, I think that's, from a public policy standpoint, I think that's an overreach on the part of government.
Well, I'm a free market guy, but the markets have failed us, haven't they?
I would agree that the markets have failed, but when you look at the reason the markets have failed, I'm going to take the risk of insulting everybody in the room. It isn't because of the hospitals. It isn't because of the pharmaceutical companies. It's because of the employers. The employers who purchase healthcare have not been willing to be aggressive. They don't buy healthcare, and who stands up for the small guy? They don't buy healthcare like they buy everything else, like how they buy steel, how they buy electricity, how they buy legal services. They don't buy based on cost, and they don't buy based on quality. The view of most employers, and I've worked with many employers for over 40 years on how they buy their employee benefits, is that they want to give employees choice, as if there's a value in choice. And the challenge that you have is, as a patient, how do you know where you should go? What information exists to tell you where the quality is, et cetera, et cetera. So the employers have to play a role. under ERISA, we all have focused on the retirement side of ERISA that puts forth fiduciary standards for employers. What nobody talks about is that same federal law that provides fiduciary standards also applies to healthcare. There hasn't been a legal challenge yet to employers to say you're offering a hospital network with every hospital in the town, even though there's market disparity in terms of quality by certain service lines, and you haven't disclosed that to your employee. Have you violated your fiduciary responsibility? And I think that wave is coming.
Rick, clean this up for us. Tell us what we should think going forward. And, what did we hear here today and what can we do with this information?
Thanks, Joey. I'm going to elaborate a little bit more and answer that question as well on Bill's perspective. I would agree that employers are instrumental in making this something that the individual's employees can understand and how best to utilize. Most healthcare services are not shoppable. If you need a joint replacement or something, you can investigate and shop for those services. Those shoppable services make up maybe 10% of the total healthcare spend. The healthcare spend really is driven by the heart attack, the event that you didn't plan. So getting good information in individuals' hands at the time they need them is going to be quite instrumental. I would, again, echo Bill's comments in appreciating what the representative brought forward, he and colleagues, as a good starting point of discussion. I was sharing with Bill earlier that 5 years ago, I said that the healthcare mess we're in is not sustainable. I was saying that 10 years ago, and I was saying that 20 years ago, and somehow we're still here. Are we at that tipping point now? Are we at that point that the individual premiums have climbed to a point that people aren't able to buy insurance? When employers are passing on to their employees through paycheck deductions and high deductibles, are we at a point where that's not sustainable and we need something different? I also want to just opine that most of us, maybe in this room, and certainly most of us in Colorado, aren't going to be governed under this arrangement, as the representative mentioned, not only because it's initially addressing the individual market, but most of us are in self-funded employer plans. Self-funded employer plans with decision makers outside of Colorado. And they like uniformity, they like consistency, whether your employees are in Wyoming or Florida or Colorado. And so it'll be important to recognize what type of adoption a program like this would have in, say, the small employer market, should and when it expands to that, but also will there be large employers who will adopt this type of a program? We haven't seen that in the past. As Bill mentioned, I think that many of my former clients I worked with in the employee benefits consulting side were their HR departments were very concerned about disruption, and they didn't want to have too many emails off to the CEO complaining about the benefits program. So they gave choice, and they tried not to be very disruptive in their employees' lives, but they really weren't banding together to achieve the best economic outcome through that purchasing. We've worked with some employer coalitions and appreciate what's happening in Summit County and elsewhere to have the market come together and help drive solutions as another arrow in the quiver of what can be accomplished.
Gentlemen, thank you very much.
I think we have I'm sure that there are some questions from the audience. I think we have time for several, so sure, Paul.
Dylan, quick question, then I have a couple of comments. The public option applies only to the individual market, is that what I heard you say?
Yes, that's what the bill says, that it'll be an individual market product sold on the exchange.
So let me debunk a couple of myths the three of you talked about. You said, Rick, it's a free market. We don't have a free market healthcare system. We have none of the attributes of a free market. There's no transparency, there's no accountability, and there's no choice on the part of the consumers. We have no free market healthcare. Dylan, you said people like their employer-based health insurance. I think that's nonsense. I'm a business owner. I don't know anybody who likes their employer-based health insurance. I don't know employers who like it. I don't know employees who like it. What I hear constantly is complaints about rising premiums, rising out-of-pocket costs, limited choice, etc. The comment was made, Bill, you blamed employers. Employers are put in a box. We have limited things that we can do. We because of the way it was structured. The Affordable Care Act has delivered on none of its promises. It's dramatically increased cost. It has had minimal impact on access. The entire growth in access has been in the Medicaid world, and it has arguably affected quality. So my question for all of you is, why don't we get out of this box and start thinking about real solutions? We keep looking for a government answer. Government doesn't have the answer in healthcare. We've seen that over and over and over again. It keeps making it worse. I'm an employer who has no group health plan. I have 46 employees who all have individual plans. They spend less, and I spend less, than we would spend in the group market. So there's a myth that the employer market, the group market's cheaper than the individual market, and it's not because of the governor's subsidy of this year. It's always been that way for us. The one positive thing in the Affordable Care Act is it made it possible to insure everybody with pre-existing conditions. I would attribute the only beneficial thing in the Affordable Care Act to be that one thing. I dread getting to 50 employees because suddenly now I'm subject to all of the regulations of the Affordable Care Act. I suggest to this group, go to Amazon, look up the book by Steve Hyde, just hit Amazon this week, called How Jeff Bezos Can Fix the Healthcare System, Leading the Transparency Revolution. It's free for the first week on Kindle. Go get it. It's a fantastic read about what could actually happen to fix the healthcare system. This public option is not the answer.
So do you think the answer then is government-run healthcare?
Absolutely not.
So what is the answer then?
Well, the answer is pretty simple. Let's create a market that has transparency.
And how are we gonna do that?
How are we gonna do that? You get the government out of the way. You have three elements that you need to.
After we just discussed the failure of the free market system in healthcare, you're saying get the government out of the
There
way?
isn't a failure in the free market system in healthcare. We don't
You
have
just
a-
said it's a failure in the free
No, I
market
said we
system.
don't have a free market. What I said was we don't have a free market system in healthcare.
We had one before.
We have a completely distorted market in healthcare. It's not a free market. It has none of the attributes of the market I participate in. It has none of the attributes of any of the markets any of the business people here participate in. I get asked about price every day, 10 times, 20, 30 times.
Well, my solution is people just don't get sick, because it's just as workable as yours is.
Well, one of the things that would happen in the Steve Hyde vision of the future is we take better care of ourselves because there's reasons for us to take better care of ourselves financially, and a huge part of the cost of the healthcare system comes out of the healthcare system. A third of the cost of the healthcare system is in preventable illness. A third of the cost of the healthcare system is because we smoke, we drink too much, we're obese, we don't exercise. We could have huge costs drop out.
Okay, so I want to end on time. I know that there's other hands, so we could go on and on. Dr. Washington.
Thank you. I may be the only physician in the room. I think is that true? I think it's fascinating. We're talking about healthcare, and there are no healthcare providers on the panel. I think that's an interesting observation. I'm just going to say several things, and you don't have time to answer them. Coverage is an issue, so I applaud you for addressing that. That's where we part ways. Let me tell you why. You alluded to part of the reason why healthcare is so expensive, and it's addressing the hospitals. It's not addressing all the other issues related to healthcare delivery, such as pharmaceuticals, suppliers that make MRIs and the like. But no one's talking about patient responsibility that you alluded to. Patients in your proposal can go to the emergency room for anything and get reimbursed. Why do you allow people to go to the emergency room if they have a sniffle or a broken arm or something like that, when there are other, much more cheaper ways to access the healthcare system? That's an issue. Bill, you brought up something fascinating. Hospitals that do not pay taxes also make margins. They make money. However, the bill says that if you're a tax-paying entity, you get reimbursed less. If you're not a tax-paying entity, you get reimbursed more. I don't understand that because the cost of care for both is the same. The final thing is the reimbursement rate. You're absolutely correct. For some things, the reimbursement rate suggested would pay for most things. But I can tell you it won't come near paying the cost for the bone marrow transplant. If you're a premature baby, you're 28 weeks, you're going to be in the hospital 3, 4 months with very expensive healthcare, the reimbursement that you're proposing will not pay for that. So hospitals are going to be forced to say, you know what? If you're a premature baby, we can't take care of it. If you need a bone marrow transplant, if your heart didn't go well, we needed a heart transplant, hospitals are going to be forced to say, you know what? We can't afford to do that because we're going to lose a lot of money. So people need to think more about those things rather than just hospitals paying the brunt of the cost. Hospitals do have some of the cost, but not near as much as being proposed in the bill.
Thank you. Responses, panelists? Representative Roberts?
Sure. Well, no, I mean, those are all fair points. I think your initial point about changing patient behavior is, I don't think that would be the role of government of telling people how to handle their own decisions in their healthcare. You know, again, this is a very limited proposal with a very limited number of Coloradans who would end up purchasing it. So the numbers show that because we're talking about such a small number of people who buy the Colorado option, the reimbursement rate that is set is not going to have any disproportionate impact on the market because the amount of people that it covers going into a hospital's doors are going to be, you know, at 10% at the most, I think less than that. We're trying to help the people who don't have health insurance coverage right now because it's too expensive and because there's no choice. You know, it's funny when you propose, to all the questions, when you propose changes in the healthcare system, this is what I found as the responses. Oh, well, you know, that is certainly not the idea. We need to fix healthcare, but that is certainly not the way to go. But, you know, you never hear those ideas on the front end. So I would invite all of you, you know, my information is public and I am always willing. If you have a better idea on how to get my constituents more access to insurance and increase competition in the market by lowering prices, I'm all ears, and I'll do it in a bill or we'll do it outside of government. But we don't hear from you until there's a bill like this that's been introduced.
Bill, Rick?
Well, responding to 2 points, what are the other alternatives? One other alternative that is being tested right now is the Colorado Business Group on Health is putting together a coalition of employers that will attempt through the free market to negotiate directly with providers in a free market basis and to come up with rates that would be significantly different than what our people are paying right now. And to have the purchasing be based not on price, but based starting with quality. And so providing transparency, and there are myriad of quality assessment tools out there, but one of the best is a group called Care Checks that Quantros has developed that really looks at reliability, the probability of someone being discharged and having to be readmitted for a hospital-acquired infection, that sort of thing. So cost and quality, but private sector driven, employer-led. So this Colorado Business Group on Health is forming a board of employers and unions, trusts, and others who will sit and make the decisions as opposed to relying on the insurance industry or others. That group is going to start with self-insured employers first, just simply because that brings a mass of bodies. And then in the second year, moving to the fully insured and individual markets as well.
Rick, any?
I think the challenge will still be how long are we willing to wait? Is there an urgency that we need to act now? Are there programs that we should be looking at that have a longer term payoff? I would add maybe to Dr. Washington's comments that we use Medicare as a benchmark oftentimes because it's one of the only benchmarks out there. But there are many programs underway right now that look at value-based purchasing and paying on quality, as Bill mentioned, and paying on integrated care, bringing the physicians and the hospitals together, and moving to a Medicare-based payment schedule is, in my mind, somewhat of a de-evolution that is taking us back to a fee-for-service medicine that we're trying to get away from, and having more coordinated care and having more financial alignment of incentives.
So to be on time today, we're going to wrap up. I'm going to take the liberty of having kind of a final word on this topic. Look forward to CSPR's study on this bill in the next several weeks. Representative Roberts mentioned the stuff that's on your table right now doesn't necessarily apply. We argue that it does. There's a lot of questions still to be unanswered about this current bill, and I'd encourage you to read through those questions, and we look forward to continuing dialogue with the bill sponsors to answer some those questions, especially around what potential unintended consequences might result from this. What is that medical loss number? How will this impact quality of care? How will this impact the other different markets, group plans, employer-sponsored plans? So we will be releasing a study on this current bill, and we look forward to continuing the dialogue. Thank you, panelists, for being here. So a few final wrap-up items. Thank you to our Leader Circle members. A lot of you are here today for being a member of CSPR. We are a 501c3 nonprofit. We rely on support from members like you, individuals and associations that support this important research. So we make sure that we have the best public policy proposals moving forward for the state. Joey, I'm really disappointed that you didn't wear your white tux and top hat.
I promised to.
Next time? Okay. We hope that you will join us at our next Eggs in the Economy. It will be on May 21st, so please mark your calendars. And a few other things, if you'd like to follow or learn more about our different research that we have going on, check out our website. As Lauren mentioned, we also have a podcast that's available on Apple and a lot of different podcasts platforms. Follow us on Twitter, Facebook. And with that, look forward to seeing you all soon. Thank you.
Good question.